And now into our specialist test. We will begin with Thrombophilia screen. And Thrombophilia screen is a special coagulation test, a bunch on its own, but it contains individual tests performed that give a good connection and interpretation of a person's chances or a person being predisposed to clot formation. And just mind you, when we say thrombophilia, thrombos is clot and philia means loving, meaning a person predisposed to clot formation. It's different from hemophilia. Hemophilia is a person at risk of bleeding. Now let's mention the individual tests that form hands for thrombophilia. These are the antithrombin test. You have the protein S, the protein C, activated protein C, and a genetic test we call the factor V Leiden. You will join each of these together, interpret it and make it simple, and understand how these tests relate to a clinical status. Lovely. We can't progress with this without knowing the normal status of a blood vessel, the vasculature, and the contributions they make into maintaining the thinness and the thickness of blood. Look at this structure. Now I have divided them into two. We can see a normal vessel that is no injury, and we can have here that a vessel injury that has got tissue damage. If you look up here, this is a resting stage of a blood vessel, and everything put into place for the relaxation of the muscles, the smooth muscles of the vasculature, and also for a free flow of blood through the blood vessels. Then let's study the resting stage. Now we can see that there is this prostacyclin, the PGI2. It's a type of prostaglandin, but this purposely is to cause relaxation of these muscles and also for vasodilation. And this is nitric oxide. Nitric oxide is also purposefully for vasodilation. So these smooth muscles is able to relax and expand to allow as much blood to pass through the blood vessels to any part of the body that needs oxygen supply. This is the endothelial layer, which is an epithelium within the lumen of our blood vessels, and it is within them that the prostacyclin and nitric oxide are found. Progressing with the explanations, this is thrombomodeling. Thrombomodeling is the exact opposite in functional to whatever thrombin does. Remember, in previous discussions we know that thrombin is a procoagulant and is able to convert factor V into its active form, factor 8 active form, factor 13 active form, and finally able to convert fibrinogen to fibrin. We just discussed it. Looking at this, thrombomodeling binds to thrombin, change its status from a procoagulant into an anticoagulant, meaning it is unable to activate the factors that it used to once thrombin binds to once thrombomodeling binds to thrombin. Secondly, this thrombomodeling is able to bind to protein C, and know it that protein C has a cofactor protein S, and together they are able to inhibit the activated form of factor V and factor 8. This makes thrombomodeling a controller of clot formation within the blood vessels. Moving on onto other regulators found within the endothelial layer of the blood vessels, we've got tissue plasminogen activator. Not to talk longer about it, this is what we just discussed, that the tissue plasminogen activator converts plasminogen into plasmin that dissolves a clot, and it is responsible for fibrinolysis. And finally, we've got TFPI. This is tissue factor pathway inhibitor, and the tissue factor pathway inhibitor is to stop the progress of the tissue factor pathway, which is the extrinsic pathway of the clotting cascade. So the activated factor 7 is inhibited by the tissue factor pathway inhibitors. Now we understand that every potential clot formation has been resolved naturally by the presence of this vascular endothelium and its special component that makes it possible to regulate the thickness and thinness of blood. I'll just flash through this portion because we've discussed almost everything here. But just by the way, also in the vascular endothelium during a blood vessel injury or tissue damage, this is thromboxane A2. All these here are the exact opposite of this prostacyclin and nitric oxide. These two cause vasodilation and relaxation of the muscles. This one causes vasoconstriction because it comes out during an injury, which helps the blood vessels to constrict and also help activate platelets. They all work together to activate platelets to be directed onto the path where there is an injury. This is the tissue damage exposing the vascular endothelium and all the factors that contribute to healing or sealing an injury. One last thing I will mention here is these Weber-Palidae bodies. The Weber-Palidae bodies are granules within the vascular endothelium. They contain von Willebrand factors, and technically they contain the ultra-large von Willebrand factor multimers. These multimers are released into the blood vessels when there is 1. An injury, 2. an infection, 3. an inflammation. So the 3 I's cause the degranulation of the Weber-Palidae bodies, which are granules, and release ultra-large von Willebrand factors. Where again do we get these von Willebrand factors? When platelets are released and they degranulate, they are alpha granules within platelets. When the alpha granules degranulate, they also contain von Willebrand factors. So the 2 main sources of von Willebrand factors are within the alpha granules of platelet and also within the vascular endothelium in the Weber-Palidae bodies that release them. We will bounce back onto our thrombophilia screening, but we've solved almost 80% of understanding within the thrombophilia screening. Looking at protein S. Protein S and protein C work together. So protein C is responsible for inactivating the factor 5 and factor 8, and protein S is a cofactor that contributes to the activity of protein C. If there is a low level of protein C and protein S, it means this factor 5 and factor 8 activated will continue to cause clot formation, predisposing the patient to thrombosis. Secondly, the protein C interact with factor 5 and factor 8. In case there is a genetic aberration or a mutation of the factor 5 gene, though it will remain a procoagulant for a clot formation, however, in the process of protein C interacting with this factor 5, it is not going to have its affinity binding onto it because the structure here is mutated, and therefore the clot will continue to form even though we've got protein C and protein S. But the factor 5 here that we have got is a mutated, and the mutated form is what we called Leiden, factor 5 Leiden. And this is the reason why we do the factor 5 Leiden test as a part of thrombophilia, to see if there is the mutated form of factor 5 or the normal factor 5. Also, we've got an antithrombin. Now you will align antithrombin to the same status as thrombomodeling at this point. So antithrombin means it is against thrombin, and I think we've talked about it before. So the antithrombin is responsible for binding it to thrombin, changing it from its procoagulant status into an anticoagulant, meaning the thrombin activity of activating other factors will not be undertaken, and therefore there is no clot that is going to form. That is the natural function of the antithrombin, and the antithrombin test is performed to see if the antithrombin that we have is enough or is structurally functional to be able to bind to thrombin to stop its clotting process. Now we have discussed protein S and protein C. We have talked about the factor 5 Leiden, and we have talked about the antithrombin performing almost the same function as thrombomodeling. And finally, the other test that we do in thrombophilia is activated protein C. Let's have thrombophilia test explained. So we are going to look at the individual tests that come together to form the thrombophilia screening, the principle regarding each test, and how their results or outcome contribute to interpreting thrombophilia screening. Beginning with the first test that we say, starchrome protein C. On the stego analyzer, when we hear starchrome, it means that that test uses a principle of chromogenic. And when we say star clot, it means it uses the clotting principle. Beginning with starchrome protein C. So the reagents that we have for starchrome protein C test are the substrate. This substrate is a color changing substance that changes color when they are bound to. There is a protein C activator. That protein C activator is called a protact, which is a venom. And what the venom does is to convert the protein C available within the patient plasma into an activated protein C. And remember that the activated protein C is a serine protease, just like protein S. and they are also vitamin K dependent. As a serine protease, the activated protein C cleaves this substrate and converts it into a color. This is a color changing substance used as a substrate. Therefore, this color changing substance will give this yellowish coloration within the cuvette, and this is an electromagnetic wave that controls the movement of this ball for uniform formation of whatever solution we get in here. A light travels through, and the absorbance is equivalent to concentration. So the higher light is absorbed, the more concentrated this solution is, and the lower absorbance obtained, the less concentrated the protein C found within this. So this related onto the Berlambert's theory to determine the concentration of protein C in the patient's plasma. We are done with that. We've explained the importance of protein C in the previous videos. Now we move on to the second test, which is the star clot APCR, which is the activated protein C resistance. And this test is a clot-based test, and this will have a different principle from the star chrome protein C. To make this explanation easy and understandable, let's make reference to the protein C. Now we will go one step back onto these diagrams, and we know here that when thrombomodulin binds to protein C with the help of protein S, it cleaves factor V. So we know that activated protein C binds to factor V and stops it from continuous clotting process. Now we know what protein C does when it is activated. So it has a direct link with factor V. So in testing for activated protein C, you will definitely need factor V. But does factor V work alone? Then one more step backwards into the clotting cascade. Here we discuss that when thrombin activates factor V, this is factor V, it joins hands together with factor 10 to convert prothrombin into thrombin. Great. So when we are doing an activated protein C test that directly depends on activated factor V, we complement it with factor 10 so that we get a joint reaction on prothrombin, so we can interpret the activity that protein C exerts on factor V. Now let's go back and explain the APCR test. Great. We now know that we will need factor 10 activated, found here. We now know that we will need factor 5 activated. But interestingly, this reagent is to make sure that we are providing all other factors, removing all other factor deficiency interferences, and allowing only the patient's own factor 5 to undergo this cascade. And here we have the inhibitor or the resistance. This is APC. We know that when protein C is activated, called the activated protein C, it resists factor V. Now the clotting process is interesting here. We move down here. This is electromagnetic wiring with a cuvette present in here, and there is a magnetic ball. What this wiring does, electrical connection does, is that because the ball is magnetic, it will be dangling between these magnetic poles, moving up and down, oscillating within the cuvette until it is no longer able to move because of turbidity. Now let's do the pipetting. We've got the patient plasma here. A portion is taken into this cuvette, and we've got the immunodeficient factor except factor 5. Every other factor is here. A portion is pipetted into this cuvette. Now when this cuvette is incubated with a venom which activates factor 10, it means the factor 10 here is activated. And remember, the factor 5 here in the patient's plasma with all other factors are also activated. So all other factors are activated. In the presence of the APC, that is the activated protein C, the factor 5 present here is resisted. If it is resisted, it is going to take a longer time for a clot to be formed, meaning the ball will keep oscillating in a very viscous environment, and for a very long time it will not become turbid. A clot will not be formed because the factor 5 have been hijacked by APC. And the reason why we interpret APCR results with the factor 5 laden is because of mutation or a possible mutation in the factor 5. So when the factor 5 is mutated, it is called laden. But let's get this right. if there is a mutation, it doesn't mean the factor V will be non-functional, but it means the factor V will not bind to APC for resistance, and therefore a clot will continue to be formed. A person is subjected to thrombus formation or clot formation without resistance. This is what we call APCR. And to interpret the results that we get out of this, if there is mutation, which means APCR cannot bind to the factor V, what happens? A clot will quickly form because the factor V there is not resisted. So the normal results we expect to get is to obtain a prolonged result, meaning our APC is very potent and it is able to bind to factor V with affinity and avidity in case the body wants to regulate the clot formation. Now have a look at this formula. This is the reference. The result should be greater than 2.1. So the result is calculated this way. It is the APTT with APC, which means it will be prolonged, over APTT without APC, which is the normal APTT results of the patient without any resistance. And this ratio gives the APCR results. Now it means we are done with star chrome potency, we are done with star clot APCR, and we have linked it with factor V Leiden. And then we go on to our fourth and fifth test. This is the Liar test free protein S. And when you hear Liar test free protein S, it is an antigen antibody binding, which is an immunoassay reaction where a monoclonal antibody is directed toward an antigen of preference, and this antigen of preference is the protein S. This is why we call the free Liar test protein S test as immunoturbidometric assay. What are the reagents that are involved in this test? We have the latex and buffer. The latex is a polystyrene latex particle with a coated monoclonal antibodies, like I've mentioned previously, and the buffer in here is to dilute the patient sample and also maintain the reaction in a normal pH. So when you add the patient sample to the latex that we have as a reagent, they form a strong antigen antibody binding. This complex makes the reaction turbid and through a photometric method where light is passed through this. So imagine from the beginning of the reaction, light will pass through until at a point light cannot pass through this anymore. The absorbance at this level is interpolated into concentration. So the higher the absorbance, the higher the concentration, and the lower the absorbance, the lower the concentration of protein S available in the reaction. So this uses photometric method to calculate how much protein S we've got in the patient sample. And just a clue for remembrance, you should always remember that this turbidometric assay does not only conform to the free Liar test protein S test. Most other tests, there are other tests that also uses this antigen antibody binding. For instance, the D-dimer test uses the same principle. The von Willebrand testing, which talks about the von Willebrand antigen test, also uses this method, and probably more tests to come that may use these turbidometric assay as well. Now onto our last test that we are going to interpret. This is very straightforward, and the reagents that we are going to use are listed here directly, and you will know that you use two reagents here, even as we used two reagents here, the latex and the buffer. So on the antithrombin test, what we are going to need is that we will need a thrombin, because the name is self-explanatory. This is antithrombin. It means that whichever antithrombin 83 you have got in the patient's plasma is going to attack this thrombin, or it's going to bind to and inhibit this thrombin. But the knowledge behind is that this thrombin is measured. It is a known amount of thrombin within this test. So a known amount of thrombin, but the amount of antithrombin within the patient plasma is not known. However, the volume is specific. So a specific volume of this patient's plasma is pipetted into this cuvette, and a known amount and a known volume of this thrombin is also pipetted into this cuvette. Now the reaction going to happen in here is that the antithrombin will inhibit this thrombin, and the amount of thrombin that will remain uninhibited will convert this chromogenic substrate into a color that we are seeing here. So this yellowish color is assumed to be the end reaction, and this resulting color is inversely proportional to the concentration of antithrombin found in the patient's sample. This is very smart, easily understood, and it's quite interesting to know. The reason why it is inversely proportional is because looking at this reaction, we knew the amount of thrombin and we knew the volume that came into this cuvette. And we know the volume of antithrombin that came into this cuvette, but we don't know how much antithrombin was there. And it is only this thrombin that is able to bind to this chromogenic substrate, cleaves it, and causes the color change. So this color change resulted here is as a result of thrombin binding to the chromogenic substrate. So in the reaction here, we will begin with the patient sample plus a known amount of thrombin. The antithrombin in a patient sample will bind to this thrombin, and some of them will remain. But how much or how less will remain unbound will depend on how much antithrombin came from the patient sample. So if there is too much antithrombin within the patient sample, most of the thrombin will be bound, inhibited, and very less of the chromogenic substrate will be converted into color, and therefore the color will be lighter. This is inversely proportional because the color became lighter because most of the thrombin has been inhibited by the too much antithrombin in the patient sample. That is great. On the vice versa, if very few antithrombin is obtained from the patient sample, then most of the thrombin will remain unbound, free to convert the chromogenic substrate into a color. The color will become deep, and the deeper this color, it means the more thrombin, which means the less antithrombin present. So it is interpreted that way. And whether you are using a semi-automated or a fully automated or a manual method, your reactions will be interpreted along this knowledge in chromogenic assay. If you are very glad and is quite blessed with this sort of education and you find it easier to understand, I would urge you to click on the like button, follow me or subscribe to me on YouTube, TikTok, Facebook, and let's have further educations in this kind of manner. Thank you very much for your time watching this video. See you some other time.